Okay, at the outset, I would like to thank you, everybody. And it was a great pleasure meeting everyone. And I would like to come in, thank Dr. Abu Bakr for giving me the opportunity to participate in this course. And
greetings for Dr. Abu Bakr.
Yes, a great leader, really investing in his staff and believing that we can accomplish. Yeah, he's really a great leader. The project is about it was about the patient identification. Next slide, please. Okay, patient identification. The reason of choosing the patient identification as a project is that it is one of the required organization practice. As per the Canadian and the GCI, it's really a must to have to be compliant about a patient, to have a complete patient identification. Next slide. So according to the Canadian accreditation, we need to work in partnership with client and families. At least 2 person-specific identifiers are used to confirm that clients receive the service or procedure intended for them. And also, according to the Joint Commission, to reliably identify the individual as the person for whom the service or treatment is intended, and to match the service or treatment to the individual. So from these 2 standards, different accreditation bodies, so we need to make sure that the right patient, to confirm that this is the right patient in order to give him the right service and eventually to prevent any harm to the patient. Slide, please. So this was an opportunity, and starting from these standards to ensure the compliance, we had also a few reported incidents. It wasn't much, but the impact of the incident were a little bit high. So we thought that we need to see whether we are really compliant. Complying with the accreditation standard or not. So this is the opportunity to improve. We organized the team from the stakeholder, different departments, from medical record, from nursing, from reception, and from quality department. So we organized the team. Next. So to clarify the process, we studied the initial process. The patient will come to the reception at the office, the registration office. The staff will ask the patient the telephone number, and from the telephone number, they will just extract the electronic file, and then they will say, well, is your name is XX? The patient will confirm. And they will see if it's new patient or not. If it's a new patient, they will open a file. And if it's an old patient, you'll just request the file. After that, they will print the label. Once they print the label, the nurse will take the label. If it's inpatient, directly they will put the label, whatever procedure they want to do, and they will say, well, are you Mr. XX? And the patient will confirm, and eventually they will continue with the procedure. In OPD, or if it's phlebotomy or radiology, the nurse will take the label and she will say, is your name is such? And the patient will confirm. She will put the label on the request or the file or the document. The doctor just will fill it, and then they will complete the form, and that's it. In operation theater, also the nurse will check the file. There was no team working in the checklist, safety, the operation checklist. And in nursery, also the nurse used to use the room number to give the baby to the mother. So this is what we noticed that the usual process was. Next.
Okay, kindly, I want to know
Okay.
where will be
Fine.
your edit exactly through this process map?
Okay, in the coming slides, I will show what improvement we have. I have made another flow chart showing the improvement process.
Okay, I want only at first
Okay.
to know at which step exactly you will work on. Do you remember that we asked you to make two flow chart diagram? I know you are doing
Yeah,
the two,
I did.
but I want from the beginning to see where will be the area, the exact area for improvement.
I made the yellow. It's the reception area, and
Yes.
also the after the diamond shape, the request the old file. Also, we made some changes. And each color in the nursing, inpatient, and OPD, each color we made also a few changes.
Okay, excellent. Next.
Okay, yes. So here, just we use the switch sheets how to show how the error might overcome all the barriers and make reach to a patient undesirable outcome. So if the reception did not complete or do the right patient identification, the doctor did not confirm the patient identification, he will miss. And the nurse will just also, if she did not do follow the policy, also will reach to other clinical staff, and eventually there might be a patient harm. Okay.
Okay.
Next. Anything. Okay. So after that, we started to ask why the reception did not ask the patient, because I did not mention before, we have a policy on patient identification that you need to ask the patient 3 names, the full name. You need to ask at least 2 approved identifiers. In our policy also, we mentioned what are the approved identifiers. We mentioned that room is not valid. The telephone is not a valid patient identifier. So when we had we processed the map of how they are doing the patient identification, we started to ask why the reception did not ask the patient a valid identifier, because maybe he's a new staff.
Yes, according to the Canadian accreditation standards, what is the most appropriate identifiers acceptable for identification of the patients?
So they said they gave the patient full name, date of birth. We can use the civil ID. We can use also the passport. Medical record and the medical record. These are the acceptable patient identifiers.
Yes. Okay.
Okay. So it depends on the patient, on the reception, why they are busy, or the workload, or the patient did not have a civil ID or passport, or some patient they will impersonate. They will use their friends or their relative ID and proceed the insurance for the insurance purposes. So, or some patient in cosmetic, they used to come and they say, I want to stay anonymous. I don't want anyone to know about my identity. So also, the other thing, why the receptionists, if they have updated the patient demographics, they did not update the file. Sometimes they will update only on the electronic file, but not the labels or the physical file. So because actually we found out that there was no policy. They did not know what they do. They thought that what they have done is enough. The nurse, why she did not follow the policy, the patient identification policy, because the new staff or the workload, or sometimes the patient will bully the nurse. They will ask, why you're asking me my name? Don't you know why are you asking me, keep repeating? So this is one of the reasons. And the doctors, why they don't confirm the patient identity, because most of them will say this is not my responsibility, or they will rely on the nurses to do everything on their behalf. and they will say, I'm too busy, I don't have time to do all this process. And why the staff, phlebotomist or radiology technician did not follow the policy? Because they're the same thing, new staff or the workload.
Excellent.
So these are the 5 Whys.
Excellent application.
Okay.
Thank you so much.
For SIPOC, we applied SIPOC here. The supplier is the patient, receptionist, nurse, laboratory staff, or radiology, doctor, pharmacist, ambulance staff, because sometimes we have a transfers, or family or relative. The input is civil ID, passport, medical record, prescription, laboratory request, radiology request, medical report, or the transfer form. The process is the same as I explained before. The output is good patient experience, patient identification improvement as KPI, and the cost will be reduced, and we will have less medical legal cases in case we have an adverse event. The customer is internal, the staff, the external patient, and the hospital.
Excellent.
Okay. Fish bones, the root cause, the cause and effect. We have the causes related to people rush to give care, because if they have a lot of patients, they will rush soon, and they will miss some process, some steps to identify the patient, or new staff. Causes related to policy. No training on when we implemented the policy, we did not have a training, or not including all the stakeholders, because when you put the policy, you need to have a general idea, or to include all the stakeholders, so you'll cover all the aspects. And this is the way how you overcome the barriers and the staff will be comfortable in implementing the policy.
Okay, Ms. Safa, let me ask you, from your understanding for this problem, from your point of view, what is the most important cause of this problem from the different causes?
The most important is the staff will interpret the policy according to them. So the training is really important. They need to understand what we mean in the policy. That's
so
why
from policy, people, environment, procedures, from your point of view, yes, I know it's a complex factors, but if we want to ask you, what about the exact factor, the highest dangerous factor from them is which?
Yeah, mostly is the staff engagement. They need to need to know the awareness or staff awareness.
So staff this awareness is related to people, right?
People, yes. Yeah, understanding the policy on the
Okay. Next.
Okay. Select. We need to improve the patient, the staff awareness, and to engage also the patient, also related to patient awareness, and in this. So plan emphasis on policy compliance, increase staff awareness, engage patients, staff training, revise policy on patient identification, periodic audits to monitor compliance. And in DO, we had patient identification project contest, revision of patient identification policy, observational. We had not only, we had observational audit. This is very important also. And we engaged the patient in the process.
Okay.
Okay, so this is the improvement process. The registration staff, we emphasized on them to use 2 patient identifier instead of.
Now your addition is the yellow boxes, right?
Yes, the yellow boxes. So we emphasized that no opening the file or no requesting the file without having a patient, the civil ID, a valid, and they will confirm the picture of the patient with the personal patient in front of them. So, and also upon updating the demographic, we have a policy that the patient, if they want to change the name or anything, there is a form that need to be filled, and later on they will send it to the manager, and we will take it from there. Regarding the nurses, they need all of them to ask two patient identifying the full name and the date of birth. And also we engaged the doctor. There was a memo from the higher management that they are accountable if they will sign on anything, that even if they don't put the label, they are held accountable and responsible for anything they will sign on it. And we encourage the nurses, and we ask them that they are not allowed to put any label on any request. So the doctors now are putting the labels and signing. In the operation theater, we have another team looking into the surgical safety checklist as completion of the form and observation, two different audits. So we have now more teamwork inside the operation theater. And in nursery also, we had the training that we will not use the room number, always checking the baby, the bracelet of the baby and the mother bracelet to confirm that this is the right baby. And so these are the improvement that we had through the trainings and the other measures.
Excellent.
Okay.
What about check?
So check, I will leave it now to Dr. Huda. She will take over.
Thank you, Ms. Safa. Very, very great, excellent effort. Thank you so much. Welcome, Dr. Huda.
Hello, everyone. Welcome. And I will continue Dr. Safa presentation. Okay.
Yes.
Here, continue the Bidika, focus Bidika. Okay, we have the check. Okay.
Yes.
Regarding the check, the Royale Hayat, they have 3 criteria, okay, when they did the project to be fulfilled, okay. We start with the 4 C's, okay, C1 and 2 and 3 and 4, okay. And based on these criteria, we did the survey or the data that we collected from the 3 departments, which is the nurse, reception, and the phlebotomist, okay. And this is the, if you just scroll down, بس ممكن تنزل تحت دكتور، تنزل تحت.
Okay.
We did 7 tools, okay, 7 improvement tools. And this is the first tool, tally sheet. Tally sheet, basically, we noted all the areas, the departments, okay, according to the year.
But sir, I'm asking, after check, we have act. What about act in focus BDCA?
هي تحت, it's down.
Okay.
أيوة.
Okay.
ممكن تحت. Okay. Okay. If you want, we can go for the act and come back to the tool. بريحكم. بس هي عشان يمكن.
Okay. Let us go to for your order. No problem. We are now with the tally sheet. Excellent.
Okay, so the tally sheet is being categorized, okay, according to the years. We have 2018, and then, for example, here we have the different departments: reception, nurse, or phlebotomist. Okay, these are the number where they are not being able to fulfill this criteria. For example, not able to ask the patient to verbalize to the identifier. For reception, it was, for example, 11. Okay, in 2018, 19, it was 8. 2020, it was 3. So as you can see, it's decreasing, okay, by the year. Okay, and the next tool we have here is the histogram.
Excellent.
Yes, the histogram basically is very, very clear that into 2020, we can find the compliance has reached 77%. This is a great achievement, okay, from 54 to 77. basically. Okay. And yes, if you go down.
But I want to tell you something. This is not histogram. This is called bar chart.
Bar chart?
Yes, histogram according to central tendency. Okay, but this is a bar chart and it's accepted.
Okay.
Yes.
Here, okay. Basically, the three criteria is being يعني colored. Okay, if you find the blue one represent 2018. Okay, and the orange is 2019, and 2020 the gray color. And the most significant one is 2019 for the criteria number 3, okay, which reach 81%. Okay, and this is the best compliance has been reached. Okay.
Why decreased in 2020 from your point of view?
Why it's been decreased? Basically, maybe there were some barrier were, I don't know, maybe some barrier were not being met. Maybe Dr. Safa can explain more about that.
Okay, next.
Okay. Here we have the control chart. Okay. The control chart, doctor, if you can see, and I also discussed this with Dr. Safa. Here we
but we have a simple problem about control chart. Control chart has no bars. Okay, in control chart we use vertical axis, horizontal axis, right to make midline, upper control limit, lower control limit, and make a line chart between them, the line process flow. So if this for control chart, I think it's better to modify it to be as the classic typical shape of the control chart, okay? Because this is not a control.
You mean the diagram, right? The points should be up
yes.
and down.
Yes.
And if I may, I put the line, but I thought it wasn't very clear, so I thought it's okay. So it's good to know. Yeah, it should be line instead of the bars.
No problem at all. We want to enhance our project, and after this discussion, we want to make edits to improve the project more. So for a histogram, before, as I told you before, this is not a histogram. This is a bar chart. If we want to make histogram, we want to act on Excel to detect the central tendency to have its shape either bell-shaped or other shape. For example, if it was histogram, he will make the higher number in the center and the lowest number right to and the left. So the same here for the control chart. When I give the Excel or Minitab the data of my mean and my upper control limit, lower control limit, and enter the data, and making the line chart, it will denote the capability of my operation to detect the control chart as a classic ordinary shape of a control chart as we learned together. Okay, so we want to make improvement for it. Okay, next.
Okay, here, doctor, we are representing the Pareto. The Pareto chart. Here, the vital few were the reception. Okay, and they are the most important department. If you can see that for the patient identification relies on this department. Okay, and we have to focus our improvement in the reception and make sure that they are improving and continue to prove.
Okay, it's nice that you discover that your vital few of the problems are the reception, and this is very good. But statistically, when we want to make the Pareto chart on Excel, also it needs some edits. For example, it will be reversed, and the line won't be this orange line. It won't be straight like this, should be curved, okay, to detect the vital few and the useful. So we want also to edit the shape of the Pareto chart using Excel or Minitab. Thanks.
Okay.
Best.
Yes, here, this is the next tool we have, which is the scatter tool. Here, I discussed this with the Safa, and basically here we are comparing the total compliance, okay, in each department with the compliant in general, okay. If they are meeting the current compliant with the total compliant, okay.
Yes.
So for example, here we have the reception, the first diagram. Here we can see that it is the relationship is descending, yani it's not ascending, okay, descending, and it is negative, okay. And this is the only significant department where we can see we can notice there is a problem in the reception. But apart from that, here in the nurse and the phlebotomist, here we can see that there is no effect, no change, nothing from their side. Okay.
Okay. Let me tell you something. When we are making scatter diagram, as I told you, we are trying to find the relation between two variables. Okay, when we are making the scatter diagram, we should identify and determine the two identifiers with two special. Want to use two colors and to detect that is there a relation or not, is it strong or partial, is it proportional or disproportional. Okay, so from my point of view, another suggestion for patient identification scatter diagram to detect if there is a relation between proper patient identification and the reception compliance, right? And with nurse compliance and with the other compliance. So it's only need to edit the statistical shape of it, but its idea is good. Okay.
Okay. So here, Safa, she put all of them all together in one diagram, the three departments. So it shows the three scattered shape coming.
From your point of view, where was the largest percentage of relation between the total compliance and what?
And the reception.
Okay, excellent.
Okay.
What about ACT?
Yes, ACT, basically we will continue about focus Batika, okay, the letter A, which is ACT. ACT where usually the staff were involved in the process of the improvement, and they follow the policy, they follow the initiative pathways for the various area units. They highlight the importance need of the engagement of the patient, as well as they put together the improvement team in order to work with the patient registration, and they redesign, okay, the process itself, and they make sure to have educational materials and awareness to the patient and the reception. This is number one, the staff involvement. And after that, they continue to do training for the staff, for the nurses, for the reception, okay, in all departments. And the physician alignment and engagement was very important, and also continuing to monitor the KPI indicators.
Excellent focus, BDCA. I want you to summarize quickly because you are running out of time, because we have only 30 minutes and you exceeded the time. So please make it quickly. The
absolutely. Safa here, she will explain for you this, because this is what happened for them as a real improvement in their hospital, and she will explain all this initiative from their side. Okay, Safa? Yes.
Okay, so as one of the questions, if you empower the staff, they will solve problems. So this is what we've done. We made a contest, and the staff started to rush to register in this contest. We said that if you want to participate, the best project improvement in patient identification will win. There will be some prizes. So we had three teams, the bloggers, the identifiers, and the diggers. And each team, they came up with a very, very good ideas how to improve to improve the statistic. So next. So I summarized some of their projects. Some of their improvement. We had a patient gold card. The patient
are really dedicated. You already made a great effort at this project. Thank you so much, really.
Okay. So they improved the gold card. They presented to the management that the gold card is costly and not doing anything. Instead, we had the QR code. This is a very good because the finance were very happy to deduct 3,000 KD, which is worth just thrown in the garbage, because patients will not show the card. And the reception area, they redesigned the area. There was more privacy now for the patients, and the reception, there is no interruption. And the staff patient survey, we had also audits. We had leaflets for the patient. We have we audited the patient. We asked the patient if the staff how they identify. We engaged the patient, and we had also engaged all the staff, the stakeholder, in the revision of the policy, and we had also a campaign. Next.
Okay, excellent.
Okay, some of the things that remarkable that the nurses have done and the receptionists, they had videos of do and don'ts, and they had also comics. It was funny, like the mistakes that they used to do, that led to a wrong patient identification as a learning opportunity. They made it as a comics, and there is also a team who created a song. What is your name? It was.
To share these videos on the group to share this excellent experience.
Yeah,
very
sure,
good.
Inshallah, yes. So, and we had a campaign and the tent, the leaflet for the patient, so that the patient will know that, and on every step the staff will come and ask your name and the date of birth. So now we have patients, they know once they will come and meet the doctor or the nurse, they will say, I know my name is, they will give the 3 names and my date of birth is such. So they will not feel bad or frustrated if someone will ask them many times, what is your name and date of birth? Okay. So, and we're still improving till we reach 100%. This is our main goal. The FEMIA, I don't know, you want me the failure mode and effect analysis?
Yes.
Okay. The first step was the registration, delayed patient registration, seeing the patient without a file because there is emergency, and the doctor did not want to wait for the file, or new staff, they are very slow to open the file, or the workload, the flow of patient is very high, or there is delay in bringing the files. So for each cause, we did some the PRN, and according to the highest, we prioritize all the causes, and
that will be my question. After making FEMIA, what did you discover what are the most important risk factors that has the highest number of risk priority number?
Okay. I don't have it in order now, but I remember that we added the printing labels.
We can check together. I think
yes. Okay.
Yes, has
504. 504 for reception. Some of the reception we're using.
Here in staff failure to follow, we have
demographic
567, very high.
500. Sorry.
567.
Yes, they understood the policy. This is what I was talking. We had trainings on and we explained what is the policy for which with each department.
That's excellent. Excellent, Fimia.
And that's why we made a pathways for each reception. So now each department, they have their own pathway of how to make the patient identification. So it will be clear for everyone what is the right process.
Excellent.
Yes.
Now you finished.
Oh, yes.
You deserve to be really the best hospital in Kuwait and one of the best hospital, not in Gulf region only, but in Middle East and North Africa, under this strong supervision from the leaders of Dr. Abu Bakr Al-Mardi and his strong team. And he is very lucky to have this dedicated, committed, professional, quality team like Miss Safa and other quality team. This was one of the best projects I have ever seen. The simple edit on the statistics will be acceptable. Thank you so much, and you deserve full mark. Thank you so much.
Thank you. Thank you very much. Thank you, Dr.
Thank you so much. Thank you, Ms. Safa. You deserve the best.
Thank you so much for your encouragement and support.
For all the remaining team who participated in this such great project. Thank you so much.
Thank you, Doctor.